And today we have the continuation of one topic which we have already discussed. We had discussed early stage hypopharyngeal cancer, and today we are going to talk about the advanced hypopharyngeal carcinoma and its unique features in managing uh, such an advanced stage. It has say satellite nodules or multiple deposits even away from the primary tumor, and surgery has got its own implications, not an easy surgery, and a team of doctors has to do. In some of the institutions I have seen the abdominal surgeon, the thoracic surgeon, and the head and neck surgeon, they join together and form a team and do the surgery. And at some of the institutions, surgical oncologists, they manage the show. Quite a complex topic, and I'm sure Dr. Prem Aanand is going to cover not just surgery, but role of radiation, role of chemotherapy, role of immunotherapy, and of course, the focus will be on gastric pull-up steps and complications, including, of course, the outcomes in these situations. And your session will be moderated by Dr. Anoop, your own teacher, who's an assistant professor at Malabar Cancer Center. And over to Dr. Prem Aanand, who's going to present management of advanced hypopharyngeal carcinoma. Over to you.
A very good morning to everyone. The topic of today's discussion is about the management of advanced hypopharyngeal carcinoma with special mention regarding gastric pull-up reconstruction. Proceeding on. Let's start the topic with a little bit of anatomy. Hypopharynx is a tubular structure present behind the oropharynx and the larynx. It extends from the inferior border of the hyoid bone to the inferior border of cricoid cartilage, and it has three subunits: the post-cricoid region, a pyriform sinus, and a posterior pharyngeal wall. The post-cricoid region is the area behind the cricoid region. It is covered with mucosa and extends superiorly from the arytenoid and the superior aryepiglottic fold to the and inferiorly to the cricopharyngeal muscle. The pyriform sinuses are paired structures present on either side of the larynx. They are inverted conical in shape and they have superiorly open bases. They are laterally bound by the thyrohyoid membrane, medially bound by the aryepiglottic folds, anteriorly bound by the pharyngoepiglottic fold, and posteriorly bounded by the cricoid cartilage. And they extend to a point just inferior to the post-cricoid region. The posterior pharyngeal wall extends from the Passavant's ridge to the inferior border of the cricoid cartilage. It has a muscular cover, and it contains the middle and inferior constrictors. It is separated from the prevertebral muscles by the prevertebral fascia and the retropharyngeal face. Moving on, let's look into the epidemiology of hypopharyngeal carcinoma. According to Globocan 2020, hypopharyngeal carcinoma is the 15th most common cancer in India, with over 28,000 new cases found in the year of 2020. This accounts to about a 20% of head and neck carcinoma. The incident rates are highest in India and France. So at the time of diagnosis, about 15% of hypopharyngeal tumors are confined to the hypopharynx, whereas 65% presents with the regional spread and 20% presents with distant spread. Hypopharyngeal carcinoma are peculiar in a way that they have a extensive submucosal spread. The excellent field cancerization of hypopharyngeal carcinoma makes produce a multiple neoplastic foci, and the rich lymphatic supply of hypopharyngeal carcinoma adds to its metastatic potential. And also, the location of hypopharynx makes the spread of carcinomas spread easily to oropharynx, larynx, and esophagus. With all this consideration in mind, the patient should be evaluated with the proper history taking with careful attention towards tobacco and alcohol usage. Relevant history pertaining to aspiration, breathing difficulty, change of voice, and ear rate should be taken, and examination of the patient should be done to rule out neck notes, splaying of laryngeal framework, laryngeal capitis, and stridor. Examination of a patient with a hypopharyngeal malignancy is not complete without a fiber optic laryngoscopic examination. Fiber optic laryngoscopic examination is an important tool because it provides the physician with a rough idea about the site of origin of the tumor and rough idea about the extent of the disease. It also helps in denoting the functionality of the laryngopharyngeal unit, and it also aids the physician in with the tissue diagnosis if at all required. But the pitfall of fiber optic laryngoscopy is that it is an office-based procedure, and for some patient, it might be cumbersome because of reflexes, gag reflex, and pooling of saliva. And also, certain areas are not properly visualized in fiber optic laryngoscopy. So, after a fiber optic laryngoscopy, a direct laryngoscopic examination under general anesthesia is mandatory. So, a direct laryngoscopic examination is done with the help of a bivalve expandable laryngoscope called the Steiner and Heney laryngoscope under general anesthesia. The laryngoscope is introduced into the pyriform fossa or the post-cricoid region, and the expandable valve is distended, pushing the larynx anteriorly and medially so that the posterior pyriform fossa and the post-cricoid region is well visualized. At the same time, a rigid esophagoscope can be used to denote the extension into the esophagus as well. And if at all required, a tissue biopsy can also be taken. After a proper DL-scopic examination, the patient's laryngeal function should be assessed with the help of a piece or the fluoroscopic video fluoroscopy. And the evaluation of the patient is complete after the imaging. Proceeding on to imaging, I like to present two scenarios. In scenario one, we have a patient with the proliferative growth arising from the pyriform sinus of size more than 4 centimeter with a functional larynx and extending towards the pharyngoepiglottic fold. And in scenario two, we have a patient with the ulceroproliferative growth arising from the pyriform sinus with the extralaryngeal spread and cartilage erosion with involvement of the soft tissues of the neck. So in scenario one, the patient can be subjected to a larynx preservation protocol, whereas in second scenario, surgery is the treatment of choice and the patient is treated with total laryngectomy. So what is the deciding factor that has made this decision is the laryngeal involvement by the neoplasm. So in imaging of a hypopharyngeal carcinoma, presence or absence of laryngeal involvement by the tumor determines the treatment protocol. So our objectives of imaging would be to depict the submucosal extent of the tumor, allow accurate treatment planning, assess the nodal status, assess the distant metastasis if at all present, and monitor treatment and follow-up. The various imaging modalities available for disposals are contrast enhanced contrast enhanced CT, contrast enhanced MRI, ultrasound with or without fine needle aspiration cytology, and a PET CT. The various advantages and disadvantages of the modalities are that CT is widely available. It is fast and it has few motion artifacts. It has a better cartilage and bone detail. Whereas the disadvantage of CT is that it cannot be reliably detect erosion, early cartilaginous erosion. Whereas MRI is highly sensitive and it has better resolution and it has a better soft tissue detail, but it has motion artifacts and it is more costly. Ultrasonography is cost effective and it is better for evaluation of lymph nodes, but there is always an operator dependency associated with ultrasonography, and evaluation of deeper structures by ultrasonography can be cumbersome. PET CT gives a excellent whole body coverage, and it is highly sensitive for highly metabolic tumors such as squamous cell carcinoma, but it has a low specificity and it has inadequate local detail. So what modality of imaging should be considered? So this gives us a quite a dilemma regarding it. So let's look into the literature and let's see what it has to say. First, I'd like to quote this landmark trial done by Minerva Becker in the year 1997, in which neoplastic invasion of laryngeal cartilages was assessed and diagnostic criteria with a CT scan. It was a prospective study where Becker et al. Had stated 8 diagnostic criteria for cartilaginous erosion, and the patient's CT findings were compared with the post-operative HPR findings for cartilaginous erosion. The criteria as listed by Becker were 1. Extralaryngeal tumor, 2. Sclerosis, 3. Tumor adjacent to non-ossified cartilages, 4. Serpiginous contour, 5. Erosion and lysis, 6. Obliteration of marrow, 7. Cartilage blowout, and 8. Bowing of the cartilage. Finally, Becker et al. Concluded by stating the sensitivity, specificity, positive predictive value, and negative predictive value for thyroid cartilage, cricoid cartilage, and natrinoid cartilage for each of the criteria. But he concluded that by combination of criteria 1, 2, and 5, which is extralaryngeal tumor, sclerosis, and erosion and lysis, combinedly gives a sensitivity of 91%, specificity of 68%, and a positive predictive value of 54%, and a negative predictive value of 95% for thyroid cartilage, cricoid cartilage, and arytenoid cartilage. Proceeding on, another study done by Becker et al. In the year 2028, where a revised criteria for cartilage involvement by MRI was considered. He postulated that the revised criteria was under T2 weighted imaging and post contrast T1 weighted cartilage signal. If the intensity is greater than that of the adjacent tumor, it is to be considered as inflammation. And if the signal intensity is similar to that of the adjacent tumor, and it is to be considered as neoplastic invasion. And the study was concluded with the sensitivity of 96%, specificity for thyroid cartilage involvement as 75%, cricoid cartilage at 87%, arytenoid at 95%, negative predictive value being 96%, and the positive predictive value being 72%. Later down the year, H. compared the MRI and dual energy CT for evaluation of cartilaginous inversion by laryngeal and hypopharyngeal squamous cell carcinoma. It was a retrospective study where 55 patients undergoing total laryngectomy. Their data, their CT and MRI data were retrieved, and their pathological findings were kept as standard. In this study, we can see that the ROC curve of both CT and MRI were more or less similar. And H. stated that MRI has a higher sensitivity and a higher negative predictive value. Proceeding on, and recently in 2023, a study done by Tata Memorial Hospital, Arpita Sahu, determined the protocol for CT and MRI, where they stated that CT as the primary modality of treatment, primary modality of imaging, with MRI being used for doubtful cases, USG for assessing neck nodes, CT chest used for lung metastasis, and PET used for distant mets. And they stated that response assessment to be done with the modality which the baseline evaluation was initially done. So concluding the literature, we can state that CT is the investigation of choice for identifying cartilaginous invasion. If the CT is negative for cartilaginous invasion, the cartilaginous invasion is likely negative, and we don't further proceed with another investigation because negative predictive value of CT is around 95%. In cases where we suspect a cartilaginous erosion and we have a equivocal response, then we are to perform a MRI. MRI, if at all it is positive, it has a positive predictive value of 72%. Hence, there is a chance of cartilaginous erosion. If MRI, the findings were negative, since MRI has a negative predictive value of 96%, further evaluation is stopped. So with this, we be able to clinically and radiologically assess a patient. Little mention about the staging of the patient. AJCC 8th edition. TIS is carcinoma in situ. T1 is tumor limited to one subside of hypopharynx and or 2 centimeter or in smaller dimension. T2 is tumor in which more than one subside of hypopharynx or adjacent site are measures large than 2 centimeter but not larger than 4 centimeter in greater dimension without fixation of capillary. T3 is tumors larger than 4 centimeter in greater dimension with fixation of hemilarynx or extension into esophagus. T4 is moderately advanced carcinoma, where T4A, the tumor invades the thyroid, cricoid, hyoid cartilages, hyoid bone, thyroid gland, and central compartment soft tissues. And T4B is a very advanced local disease where tumor invades the prevertebral fascia, encases the carotid artery, and involves the mediastinal structure. So, as a part of evaluation and treatment, all patients who are getting treated at Malabar Cancer Center undergo a routine rehabilitation protocol. Rehabilitation is a process by which the basic functional capability of the patient is improved prior treatment so as they can withstand the complications of the procedure. It includes a thorough dental exam evaluation, speech and swallowing evaluation, nutritional assessment, tobacco cessation, physiotherapy, psychological counseling, and patient education regarding the disease at hand. So this concludes the evaluation part of the patient. Proceeding on to the treatment part, till the early 1990s, surgery was considered the only modality of treatment for hypopharyngeal cancers. Then came into play the larynx preservation protocol through various trials, and larynx preservation became a trend, and induction chemotherapy and concurrent chemotherapy came into play, and multimodality treatment were offered for the patient. So the factors that determine deciding the treatment would be patient factors, which include performance status, comorbidities, and status of the patient, the functionality of larynx, the pulmonary reserve of the patient, reliability of follow-up, the patient's choice, and previous treatment. Tumor factors, of course, influences the treatment choices. Site, stage, and volume definitely determine the treatment choice, and treatment factors, including expertise and cost effectiveness, is also of pivotal importance and should be kept in mind. Proceeding on, so the endpoint of interest in treatment of a hypopharyngeal cancer is to attain a good disease control in the form of local control, cause-specific control, and overall survival, and preservation of organ, which is larynx and function, in select group of individuals. So the general consensus is that early stage hypopharyngeal carcinomas are treated with partial laryngectomy or radiotherapy, and in select cases, transoral laser surgery can also be employed. Advanced cases with the exolaryngeal spread, total laryngectomy with bilateral neck dissection with an adjuvant treatment is to be offered to the patient. And without an extralaryngeal spread, patients are offered concurrent CTRT or neoadjuvant chemotherapy followed with CTRT in responders. This consensus was derived. Let's look into the NCCN guidelines. For tumors T2, N1 to 3 and T3, N1 to 3, 4 modalities of treatments are offered. First one being induction chemotherapy, followed with response assessment. If the patient is having a complete response and stable disease and improved disease in the neck, definitive RT is offered to the patient, and sometimes concurrent chemoradiotherapy can also be considered. If the primary site has a partial response and a stable disease and improved neck disease, then then CTRT is offered to the patient, and for partial responders, surgery is also offered. After surgery, if there are no adverse pathological features, the patient is given adjuvant RT. If there are adverse pathological features like extranodal extension, positive margin, then Adjuvant is given in the form of CTRT, and other forms of risk, other risk factors such as LVI, PNI, patient is offered radiotherapy or considered for CTRT. Patients with unresectable neck are treated with a palliative setting. The second line of management would be partial or total laryngopharyngectomy with ipsilateral or bilateral neck dissection with a hemi or total thyroidectomy with pretracheal and ipsilateral paratracheal lymph node dissection. If the HPR report has no adverse pathological features, the patient is followed up. And if at all PN1 and PN1 is found out, the patient is treated with the adjuvant RT, and adverse pathological features in the form of extranodal extension and positive margins warrant concurrent chemoradiotherapy. Other risk features warrant radiotherapy, and CTRT can also be considered. Thirdly, the patients are given an option of concurrent CTRT. Fourthly, the patients are CNN as patient to be actively participating in a clinical trial. In cases of T4A diseases, total laryngectomy is given as the first line of management. Total laryngectomy with ipsilateral bilateral neck dissection, hemi or total thyroidectomy, ipsilateral bilateral paratracheal node dissection. The HPR, depending upon the HPR report, if there is extranodal extension and positive margin, CTRT is offered for the patient. If other risk factors are there, patient is supplemented with the adjuvant radiotherapy, and CTRT can also be considered for these patients. Secondly, the patients were given induction chemotherapy followed with response assessment, and the response assessment is similar to that of what has been discussed for T3 and T2 tumors. Concurrent chemotherapy and radiotherapy can also be given to the patients. And fourthly, patients are enrolled in clinical trials. So all these consensus, all these concepts that were included in NCCN came from certain landmark trials. Let's look into them one by one. The first trial, which provided a path-breaking scenario for larynx preservation, was the VA trial. It was done in the early 1990s, exactly 1991, where 332 CA larynx patients were enrolled for a phase 3 trial, and they were divided into two arms: induction chemotherapy arm and a surgery followed with an adjuvant RT arm. And their 2-year and the study was concluded, stating that the 2-year survival rate was similar in both arms, which is 68%, and larynx preservation was around 64%. The 10-year follow-up of the study stated that 28.8% overall survival was seen for both the arms, and quality of life was significantly better in patients with preserved larynx. This paved the way for larynx preservation. A similar study where hypopharyngeal carcinoma was included in a phase 3 randomized trial was EORTC 24891. Where T2 to T4A hypopharyngeal tumors were included. All N were included except 2C. 99 patients were enrolled in the surgical arm, and 103 patients were enrolled in the chemotherapy arm. And the characteristics, looking into the characteristics of patient included in the study, we can find that pyriform sinus and array epiglottic fold tumors were included, and stage 3 and stage 4 tumors were predominantly included. Out of 99 patients, 202 patients were randomized, 99 received surgery, and 103 patients received chemotherapy. So a 3-year survival, the induction chemotherapy group had a 3-year survival of 57%, and surgery had a survival of 43%, which is more or less comparable. And at 5 years, there was no difference noted in the survival of these two set of patients. And the disease-free survival, whereas in the disease-free survival, CT, the chemotherapy group, the percentages was at 43% and 25%, And surgery was 32% and 27%. There was the local recurrence of both the groups were more or less similar. But looking into the distant metastasis aspect of the study, 36% in surgery arm developed distant metastasis and compared to the 25% in chemotherapy arm. And larynx preservation was denoted at 42% in 3 years and 35% in 5 years. And 10-year follow-up data of the study revealed that the overall survival remains comparable in both the arms, and survival of this cohort of patients is very poor, and half of the survivors retained the functional larynx. So this paved the way for usage of larynx preservation in hypopharyngeal carcinoma. So now that chemotherapy was introduced into the modality of treatment, the possibility of concurrent chemoradiotherapy was explored, which was given by RTOG 9111, which was done in the year 2000. It was started in 1992. It was a multicentric prospective randomized trial. It compared chemoradiation, induction chemotherapy, and radiotherapy for organ preservation. Stage 3 and 4 laryngeal cancers were included in the study. Totally 518 patients were enrolled in 3 groups separately. The first group received induction chemotherapy followed with RT. Second group had received concurrent chemoradiotherapy, and third set of patients received RT. After induction chemotherapy, response assessment was done, and patients with less than partial response were taken up for surgery with adjuvant RT, and the patients with more than a partial response or equal to a partial response, they were given RT. And it was found that the laryngeal preservation rates for induction chemotherapy was 72%. For concurrent chemo radiotherapy was 84%. For radiotherapy was 67%. The 2-year LFS was 59% for induction chemotherapy. Concurrent chemotherapy 66%, radiotherapy 53%, and the 5-year survival rate was 64 for induction chemotherapy, 80 for concurrent chemotherapy and RT, and 58% for radiotherapy. Toxicities were comparatively more for concurrent CT-RT arm, with 81% in induction chemotherapy and RT arm, and 82% for CT-RT arm, and 61% for radiotherapy. Whereas it is a point to be noted that the mortality rate was also higher for concurrent CT-RT arm, 3% for induction chemotherapy arm, 3% for radiotherapy arm. This trial has pointed out the excellent laryngeal preservation rate for CT-RT, non-inferior overall survival, a lower incidence of distant metastasis in chemotherapy groups, and good local control achievable. And this data was extrapolated to hypopharyngeal tumors as well. Proceeding on, the 10-year follow-up of the study was done. So the laryngectomy-free survival for induction RT arm was 67%, whereas for concurrent CT-RT it was 81%, and radiotherapy was 63%. The overall survival was 39% for induction chemotherapy, induction chemo and RT arm. Concurrent chemo RT arm it was 28%, and radiotherapy it was 32%. Deaths unrelated to induction chemotherapy was 20%. Death unrelated to disease, was 20% for induction chemotherapy, 30% for concurrent CT-RT, and 16% for radiotherapy. The overall survival remains comparable in all 3 arms, and death unrelated to disease was highest to CT-RT arm, owing to the toxicities received by the patients by both chemotherapy and radiotherapy. So this paved the way for production of a different alternating sequence for chemoradiotherapy. This was done by a trial called the EORTC 24854. Here, 450 patients were enrolled. Both the laryngeal and hypopharyngeal cancers were included in the study. And in this, patients were divided into two set of arms. One received a sequential RT and another received an alternating RT, where the patients were given induction chemotherapy in the form of 4 cycles of cisplatin and 5-fluorouracil, and then given RT. And the alternating arm, the patient received 4 cycles of chemotherapy, but received alternating RT with 2 weekly RT regime instead of a 4 weekly regime. The conclusion was that there was no difference in survival or survival with the functional larynx in either arm, and there was lower toxicity as compared to the chemo radiation used in other trials. So this was employed. The previous toxicities that were encountered in the other studies were counteracted by this study. Proceeding on, GORTCEC 2002-01. This trial was done with 213 patients, including laryngeal and hypopharyngeal cancer. The induction chemotherapy was initially cisplatin and 5-fluorouracil. In this study, a taxane group was added. Taxane, cisplatin, and 5-fluorouracil was given for one set of patients, and cisplatin and 5-fluorouracil was given to another set of patients, and their 3-year overall survival and laryngectomy-free survival was assessed. And it was found that the 3-year overall survival was similar for both the arms, but the larynx-free survival was more for TPF arm. And they concluded by saying that TPF is superior to PF for organ preservation, and there is no survival advantages seen, and lower toxicities were compared, and there were lower toxicities as well. Proceeding on, initially cisplatin was used for induction chemotherapy. From this trial, TAX324, carboplatin was introduced into the chemotherapy for hypopharyngeal and laryngeal carcinomas. In this study, 116 patients were included. Both laryngeal and hypopharyngeal cancers were included. They were divided into 2 arms, but but instead of cisplatin, carboplatin was used. And it was found that the 3-year overall survival for TPF was 57%, for PF was 40%, and laryngectomy-free survival was 52% for TPF and 32% for PF. And the TPF was found to be superior than PF in organ preservation and had significant survival advantage. Finally, in the year 2013, after the invent of targeted agents like cetuximab, which particularly goes and inhibits the epidermal growth factor, it was included in chemotherapy. So induction chemotherapy was given with TPF, and the patients were separated into 2 arms who received concurrent chemotherapy with cisplatin and radiotherapy, and another group where concurrent radiotherapy in the form of cetuximab and RT was given. So there was no difference in laryngeal preservation at 3 months, and there is no difference in overall survival at 18 months. And it could be concluded that it is not better than the induction chemotherapy RT arm of Vortex trial 2001. So that concludes our other modality of treatment and the rationale behind the NCCN using all this multimodality of treatment. Proceeding on to the surgical aspects of advanced hypopharyngeal tumors. 2 basic surgeries are commonly performed for advanced hypopharyngeal carcinomas. One being total laryngopharyngoesophagectomy, another one being total laryngopharyngectomy. In cases where total laryngoesophagectomy is done, a gastric pull-up is considered for reconstruction, whereas in cases of total laryngopharyngectomy, faciocutaneous, myocutaneous, and jejunal free flaps are used for reconstruction. So the reconstruction of pharyngeal defects, the pharyngeal defects can be classified into 2 groups: a partial defect and a total defect. A partial defect can be simple and complex, and the goal of our reconstruction is to restore a patent pharyngeal conduit and to prevent complication. The factors influencing reconstructions are the nature of defect, the prior treatment that the patient received, patient comorbidities, disease-related outcomes and surgeons' expertise. Was postulated the ideal pharyngeal reconstruction. He stated that surgically, oncological perspective is of pivotal importance and adequate surgical margins is to be attained. And whenever possible, a two-team approach is to be employed to reduce operating time. And a simple technique that can be reproducible is to be employed by the surgeons. A highly reliable flap is to be taken for pharyngeal reconstruction with a lower complication rate, in particular to fistula and stricture. A prevention of life-threatening complications, in particular vascular rupture and mediastinitis, is to be kept in mind. And lower donor site morbidity and a flap with a very high vascularity is to be taken into consideration. Proceeding on, he stated that a single stage procedure with a short hospital stay is to be employed, and short time for swallowing and normal diet to be employed to the patient, and quality of voice with normal intelligibility to be given to the patient. I would like to quote this algorithm obtained from Stellenmarin 5th edition. So, the circumferential pharyngeal defects with the cervical esophageal extension, if at all present, gastric transposition is the only treatment of choice, is the reconstruction of choice. If there is no esophageal extension, we have to look into two aspects. The primary, whether the surgery is a primary surgery or a salvage surgery. In cases of primary surgery, if the patient has a thin thigh thickness, then a tube anterolateral thigh flap can be considered for reconstruction. If the thigh of the patient is thick, then a tube radial forearm flap is considered. In a salvage setting, if the initial therapy was a radiotherapy, the thigh thickness again, thigh flap or a radial forearm flap can be used. And in case of chemotherapy, if the patient's performance status is better and adequate, a gastro-omental flap or a jejunal flap can be used. And if the patient's performance is poor, a thigh flap, ALT flap or a radial forearm flap can be used. Looking into the literature, a study done by Joseph Disa had given the pharyngeal defect classification post laryngopharyngectomy, where he states that type 0 defects are smaller defects which can be closed with the primary closure. Type 1 defect is a partial defect with less than 50% of the pharynx report, which can be reconstructed with the radial artery forearm flap. Type 2 defects are circumferential defects with more than 50% involvement of the pharynx, for which jejunal pre-flaps can be used. Type 3 is an extensive non-circumferential defect for which a P-vectus abdominis flap was used in the study done by Disa. Proceeding on, another review of literature done by F. Mura, he had stated that after partial resection, if the tumor, hypopharyngeal tumor, is present in the lateral wall or piriform sinus, direct closure is amenable if less than 50% of the pharynx is involved. If more than 50% of the direct closure is amenable, and again, platysma, radial artery forearm flap, and ALT flap can be considered for reconstruction. If the hypopharyngeal tumor involves the posterior wall, then the direct closure is not amenable, and the reconstruction options are a radial forearm flap and a ALT flap. In case of circumferential resection, with extension to the mediastinum, gastric pull-up is the only reconstruction possibility, and without mediastinal extension, jejunum free flap, radial artery forearm flap, ALT flap, tunneled PMMC and stented ALT flap can also be considered. So proceeding on, let's look into the details of gastric pull-up. It was first described by Turner in 1936. It was modified by Ong and Lee in the year 1960, and it was further modified by Renga. The indications for gastric pull-up is that reconstruction of circumferential pharyngeal defects after total laryngopharyngectomy with involvement of cervical esophagus. The contraindications of gastric pull-up is that radiologically demonstrated mediastinal lymph nodes, previous gastric surgeries and gastric pathologies like ulcers and perforation. In these situations, will not prefer a gastric filler. And pre-op evaluation of a patient, apart from the routine pre-op evaluations of the patients for hypopharyngeal carcinoma, should include upper GI series with barium esophagogram, esophagoscopy, and then upper GI endoscopy. The gastric pull-up is done in 4 phases: a cervical phase, abdominal phase, thoracic phase, and it is concluded with the pharyngogastric anastomosis. Ideally, the patient is approached by 2 teams, a head and neck team and a gastric team. So the head and neck team proceeds with the surgery by doing adequate neck dissection, and the laryngopharynx is adequately mobilized. After mobilization of the laryngopharynx, the larynx is entered via oropharynx and laryngopharyngectomy is done. After laryngopharyngectomy, the specimen is still connected to the esophagus, and by this time, the abdominal team does a laparotomy to expose the greater curvature of the stomach. The greater curvature of stomach is attached to the greater omentum. Dissection is continued and greater omentum is stripped of the greater curvature of stomach. And it is made sure that the right gastroepigloic vessels and right gastric vessels are maintained. The left gastric vessels, on the other hand, are ligated close to the surface of the stomach. After exposure of the greater curvature, the posterior attachment of the stomach to the retroperitoneum is dissected. And after dissection of the retroperitoneal attachments, the lesser curvature of the stomach is addressed. And the lesser curvature of the stomach is attached to the liver by the hepaticogastric omentum, which is incised, and the lesser curvature is freed off. With this, the stomach is detached of its attachments medially, laterally, and posteriorly. The gastroesophageal junction is still having its attachments to the diaphragm in the form of esophageal ligament, which is incised, and the total specimen is completely mobilized as such. After mobilization of the specimen, the gastric vein is ligated, and a Porteous maneuver is done at the pylorus end to mobilize the pylorus end of the distal end of the stomach, and the esophageal hiatus in the diaphragm is opened with blunt dissection. So as to provide aid in the delivery of stomach into the neck. And after completion of, at this point, modified transhiatal esophagectomy is performed, which is nothing but transluminal everted traction stripping of the esophagus. At this point, varicose vein stripper is introduced into the cervical aspect of the esophagus through a separate opening. It is tracked down to the esophagus till it's felt in the gastroesophageal junction. At this point, the gastroesophageal junction is transected, and the varicose vein stripper is delivered outside. After delivering the stripper outside, medium-sized stripper head is attached to the varicose vein stripper, and it is reinforced to the lower end of the esophagus. After completion of this step, the cardiac end of the stomach is ligated using a blunt dissection or a stapler, and it is made into a tubular form. And it is made into a tubular form as shown in this picture. After tubularization of the stomach, the fundus of the stomach is sutured to the varicose vein stripper with 2 to 3 silk sutures of length 25 to 30 centimeters. So after this step, the total esophagus is pulled cervically using the varicose vein stripper, and the blunt dissection delivers the esophagus en toto into the cervical aspect. At this point, total laryngopharyngoesophageectomy is done, and the specimen is delivered en toto, and the stomach is pulled to the cervical point by the by retracting the threads attached to the varicose vein stripper cranially. Once completed, after delivering the stomach into the neck, the highest point of the stomach is incised under uh, gastropharyngeal gastropharyngeal anastomosis is done in 2 or 3 layers. So this concludes the steps of gastric pull-up. While delivering the stomach into the neck, it should be kept in mind that the stomach should be delivered in its anatomical position. Without this helps in should be delivered in its anatomical position so as not to compromise the vascular supply of the stomach and to reduce the soft tissue tension around it. So that concludes the steps of the gastric procedure. The complications that are commonly encountered during gastric pull-up are intraoperatively tracheal tear, mediastinal bleeding, pleural tear. Postoperatively, there can be anastomotic leak, wound infection, hypocalcemia, hemorrhage, and burst abdomen. The later sequelae of gastric pull-up are stricture and regurgitation. Proceeding on, I'd like to quote some literature regarding the complications that I encountered in gastric pull-up surgery. In a retrospective study done by Datta from Tata Memorial Hospital, it was found that the 30-day mortality for gastric pull-up surgery was 8.3%. It was a retrospective study where 60 patients who had undergone gastric pull-up surgery was taken into consideration. And the main complication encountered by them were intraoperatively tracheal tear, pleural tear, postoperatively anastomotically, burst abdomen, hypocalcemia, secondary hemorrhage, and in case of delayed complications, they encountered tracheal stoma stenosis and regurgitation. It is wise to note that pleural tear, anastomotic leak, and regurgitation are the main complications that they have encountered in their series. Proceeding on, I'd like to quote a systematic review and meta-analysis done by Butsky, where studies which had depicted gastric pull-up surgeries were taken into consideration. A total of 77 studies were taken into the meta-analysis, and the timeline for meta-analysis ranged from 1950 to 2000. So, a half century data was available in the study, and the author concluded by saying that mortality after gastric pull-up surgery has significantly decreased from 86 deaths in 457 patients in the early 1950s to 18 deaths in 294 patients. The rate of anastomotic leak was, however, 20%, similar to other faciocutaneous flap reconstruction. And the authors also suggested a hypothetical better oncological safety. But the only downfall that they had stated was that the high rates of regurgitation and the rate of neoesophageal stenosis and stricture was low. So with this, I conclude my presentation. Thank you.
Thank you, Prem. Divan sir. So Prem has covered it was a vast topic with a most of the areas he has tried to cover, focusing on the steps and complications also. So, any your comments, sir?
Dr. Anup, you may open the chat box and address the questions. There are a few.
So,
I think he covered it very well. I'm glad as a surgeon he has covered the radiotherapy part, the chemotherapy part, and covered it as a pan-oncologist. I think that is the real spirit of an oncologist. Very well done.
Thank you.
Just can you open the chat box?
yes, sir. So there's one question from the role of near total laryngectomy in management of advanced piriform sinus tumors, when to do and when not to do. So shall I go ahead with the question? So basically, the concept of near total laryngectomy is between the total laryngectomy and the voice conservation procedures. So only well lateralized lesions are suitable for a near total laryngectomy. So for this, we need a preserved recurrent laryngeal nerve and a segment of the cricoid and along with the cricoarytenoid joint and a strip of the posterior tracheal wall which is leading down to the permanent tracheostome is maintained. Basically, the concept is that in the near total laryngectomy, the phonation, we are trying to create a shunt of the tracheostome into the pharyngeal mucosa where the patient can, which is not enough for breathing. So the patient will be breathing through the tracheostoma, and when he wants to phonate, he can occlude the stoma and he can breathe. So basically, after the advent of chemoradiotherapy, the role of near total laryngectomy in T3 tumors has come down, and it is preserved for T4 tumors which are well lateralized. So indications will be in not only in PFS, also in supraglottic, in the transglottic lesion of the larynx also this can be done, where there is no extension into the interarytenoid region. So the margins, it is an oncologically safe procedure, proven procedure. Actually, article by Sultan Pradhan in 2002, good number of series. So patients which undergo near total laryngectomy. In the case of the question was basically, I think it is on advanced PFS tumors only. So those advanced PFS tumors with erosion of the even thyroid cartilage, this can be safely done, where the criteria will be to only that post-cricoid area should be free, interarytenoid area should be free. We need a recurrent laryngeal nerve, the cricoid, arytenoid, and also a laryngeo and laryngotracheal, that segment should be intact, preserving the margin. Like after preserving the margin, if that part, if we can preserve, then those patients can be considered for, it's basically a voice preservation surgery. So these are the indication, and contraindications will be, as I said, like the interarytenoid or post-cricoid involvement, and also if the cord, opposite cord, the contralateral cord, which does not provide a sufficient laryngeal remnant. The remnant should be sufficient for formation of a shunt. So I hope that addresses that question. So any comments on the same?
Any other question?
And other questions are like which cases doing MRI would be difficult. I think that's already addressed in the presentation. And salvage laryngectomy rates in beer trial versus COTC 24989 versus RTOG, that also is addressed. And combined salvage laryngectomy, the preservation rates are not mentioned, but it is, they have given for different arms where the laryngeal preservation rates are given. So that's also.
Your
Pardon, sir?
comments on the salvage laryngectomies, salvage surgeries. Dr. Anup,
Yes, sir.
your experience on salvage laryngopharyngectomies after definitive radiation and chemotherapy has been given and there is residual or recurrent disease. What is your surgical experience? What are the outcomes?
So actually, the considering the morbidity, procedures, considering the morbidity, we would say that the incidence of pharyngocutaneous fistula are a little like around 50%, like 1:2, as mentioned in the literature, a little on higher side. So we try to do it with pharyngeal, with a pectoralis cover, or those cases with. Sir, I am mentioning about a salvage laryngectomy. In laryngopharyngectomy also, we have incidences of complications that only the morbidity, the oncologically safe procedure, we are going ahead, but considering the morbidity, it is a bit morbid for the patient. But in selected patients with good performance status, age, the incidence of complications and the morbidities are less, with a good quality of life outcomes.
Any other questions? DR surgical oncology should be ready with a case in larynx and pharynx. The exam is approaching, you should be ready with the similar case. Navneet, can we call it a day then?
Okay, sir. So thank you very much, trainees and faculty members, for joining the session.
Thank you. Thank you.
Thank you.